Welcome to Black Health Matters. I'm Darryl Armistead, your host. This episode is a Zoom recording of Howard University group session led by Dr. Clive Callender.
This is an interesting article. We've had a number of people in our group who have been on dialysis and have also had kidney transplants. And this is, can you get the article up there? This is not the article.
Okay.
This is the article, but this is just the title of the article. It's not the article itself.
Okay. Well, let me see what John Buchanan can do.
And this particular article is one of the fewest, yes, as a matter of fact, the only article in the last probably 20 years in which it is demonstrated that there's an improvement in the way in which dialysis is administered, which impacts patient survival. And they, in this article, describe how ultrafiltration has improved by about 20% the survival of patients on dialysis. Patients on dialysis fare variably. There's some people who on dialysis, they work and do well. And some people on dialysis, the day of dialysis is shot. The day after dialysis, they come back to life again, and then the day they go back on dialysis is shot again. And there's some people on dialysis who have a quality of life that's close to normal. But one thing is clear, that there's about a 10% death rate from dialysis every year. So that at 5 years, 50% of the patients who are on dialysis are dead. So dialysis is a treatment that is wonderful in terms of giving you function for 4 to 6 hours a day, 3 times a week. But our kidneys work 24 hours a day, 7 days a week. And so it does a job of keeping you alive. But for some, it does that barely. And so as a consequence, transplantation is, of course, the treatment of choice for end-stage renal disease. And when you look at the death rate from patients on dialysis versus those who had a kidney transplant, you see about 10 to 100-fold improvement in survival in those people who are transplanted compared to those people who stay on dialysis. So that it is the treatment of choice for kidney failure. And so we need ways of making dialysis be associated with better survival rates. And this article actually talks about probably the only new development in dialysis treatments that has demonstrated patient survival in the last 25, 30 years. And so we're trying to get that article up. That's the article. And it's because high dose hemofiltration. And the nice thing about this, they did a study in which they studied 1,360 patients for 30 months. Many of the studies you see don't are long-term, but this is a long-term. And the hemodialysis filtration is a newer technology that does more than the old treatment used to do. The only thing about the question is whether One of the things that happens with people on dialysis is that sometimes they get washed out, and the rate of exchange of fluid is so rapid that their blood pressure drops, and they have those kinds of problems. And so, the question is this going to happen in these patients as well? But the long-term survival rate suggests that that this is something that will increase survival. And of course, 60% of those people who are on dialysis are people of color. And so this affects us more than anybody else. And so this is a new major step forward. The question is, this has been done in the European studies. What will happen here in the United States as this has demonstrated a considerable decrease in the death rates.
Is this new technique available for home dialysis?
Not yet. It's not yet. Right now, remember, this is the first phase of it. And so it was just done in this group of patients. Hasn't been done at home yet. And home dialysis is thought to be the most desirable of dialysis treatments. One reason for that is that sometimes they dialyze longer at home than they do in dialysis units, maybe going as long as 6 hours rather than the 4 that is conventionally done. And then, of course, with peritoneal dialysis, they dialyze 8 hours a day. So that's more closely approximates what our kidney does 24 hours a day, 7 days a week. So with the peritoneal dialysis, they do it 7 days a week. So that is getting much closer to what our kidney actually does. And that is perhaps the reason that peritoneal dialysis is thought to be the dialysis of choice in terms of closely normalizing those people who have end-stage kidney disease. Any other questions or comments from some of you who have actually been on dialysis and others?
I haven't been on, good morning, everybody. I haven't been on dialysis, of course, but I do know several people that are on dialysis. And I heard you say that some people can function almost normally and some, that next day they're kind of out of it. Does that have anything to do with the length of time they've actually been on dialysis?
Well, no, because we have some people who start off that way and they stay that way. We have some people. Now, it is clear, though, that the longer you're on dialysis, it takes a great effect upon you. And the longer you're on dialysis, it is likely that the worse off you will be. But we have some patients who have survived as long as 20 years on dialysis.
Yeah.
Wow.
Yeah. One friend of mine said he's been on dialysis for 15 years.
Yeah.
Not sure about the other one.
Yeah, these are the exceptions to the rule because it's about the average rate of mortality is about 10% per year. Now, the only problem is that this has been a European finding, and whether it applies to us in the United States is another question. But most of the cost of the treatment for dialysis is borne by the government and Medicare, and this is probably the only disease for which the government pays for, so that we have actually universal health care for kidney disease, but not for any other disease. It's an interesting phenomenon in which 95% of patients with end-stage renal disease are covered by Medicare. regardless of the age of the patient. So it's going to be interesting to see how this plays out here in the United States. Okay.
Has this treatment been approved in the UK? I mean, it's already,
That's a trial. It's
okay,
not approved yet,
okay.
but it's kind of looking in the future. But there hasn't been anything new in the treatment of kidney failure for almost 25 years. So this is a development that is being looked at, and hopefully this is just beginning of a new era. You can go to the next article. Now we've had many articles on aspirin and the role that it plays in cardiovascular health, and also the pros and cons of the use of aspirin, that it affects the platelets and can cause bleeding to occur. Of course, the purpose of giving aspirin is that to prevent clots, and blood clots block the circulation, and so that aspirin has a positive result. And this is pointing out that even if you haven't had a major bleeding event, that you can have anemia, a low blood count as a consequence of it, which suggests that you have a small amount of bleeding. And the question is the cost-benefit ratio. Is the benefit of the low-dose aspirin in preventing the clot, does that benefit overweigh the amount of bleeding that may occur? And so there's an article that talks about why you should take aspirin, and many articles talking about why you shouldn't take aspirin. And right now, the feeling is that unless you have cardiovascular disease, that you probably should not take low-dose aspirin, although that has been the practice of cardiologists for at least the last 10 years or so. Any of you take aspirin as a prevention?
I do.
And many do, because that was the cardiologist practice for at least the last 10 to 20 years. The reason they changed is that because many people who didn't have cardiovascular disease were taking it. For those who had cardiovascular disease, they thought it was perhaps worthwhile, but they wondered if it was really worth the risk for those people who did not have cardiovascular disease. Of course, in our people of color, when you're over the age of 40, the likelihood of not having cardiovascular disease is decreased. And that's why when you get your annual physical, when you're over 40, it's important to, of course, get your blood pressure checked, but it's equally important to get your urine tested for protein, because proteinuria is one of the first signs of kidney disease, and catching that early may result in delaying the onset of kidney disease and the progression of kidney disease.
Dr. Callender, those people who don't have heart problems, if they take aspirin, is it to prevent clots, blood clots?
Yeah, that's why the doctors were giving them low-dose aspirin, yes. And the feeling is now is that if you don't have cardiovascular disease, the risk of bleeding may be greater than your risk of getting cardiovascular disease if you don't already have it.
Mhm.
Okay, let's go to the next one.
Okay. The next one would be your choice. What do you see you like?
Just go down the line. Sure.
Drug reaches weight loss.
That's right. Yeah. This is an article that talks about retretidine, which is a new weight loss medication that has been more effective in the phase 2 studies than any other drug in the past. And so they're suggesting that for people who have obesity or type 2 diabetes, this is a drug that not only addresses the obesity, but also addresses the diabetes. And so they're therefore suggesting that this drug in the future may be the drug of choice for people who have obesity. Of course, this is competitive then with the bariatric surgery. And so people are very high on the fact that this may be a new treatment for obesity that will become the treatment of choice over the next time. Now here again, these are still phase 2 studies that have not been applied to they're not FDA approved yet. So, but these are studies that are suggesting that this may be a new treatment for obesity, which of course is one of the biggest problems in the United States, with over 50% of people of color over the age of 50 being obese. So so there are many ways of addressing that, but this is thought to be one of the newer ways of doing it. Now, one of the things that is awesome about this is that we talked about non-alcoholic fatty liver disease being one of the commonest causes of liver failure and the need for transplant. And so this drug may reduce the fat and clear some of the fat that is toxic to the liver cells. And so this is one of the articles that addresses the fact that one of the causes of non-alcoholic fatty liver disease is type 2 diabetes. And this treatment of the diabetes may help clear the fat from the liver, which is therapeutic. We talk about non-alcoholic fatty liver disease. We talk about that being irreversible, but we talk about having the early stage of it where it is treatable, and this kind of medication may reduce the fat that's in the liver that's toxic to the liver cells. Any questions about what we're talking about?
Dr. Callender, you said this drug is just an experiment stage, right?
Yes.
Okay, so we're just learning about it, but we can't ask for it yet.
Not yet, but when you see, we'll probably see an article when it gets to FDA and it's approved by FDA, and then that will be the time we will be able to take advantage of it.
Okay, how does a person get in the study group?
Oh, well, those study groups are already formed. So
Oh, okay.
yeah, that's already said. The next step is for them to apply to the FDA to get approval. And with the data like this, it should be pretty easy. Now, the consequence that is important, losing the weight is important, but the fact that you decrease the amount of liver toxicity and liver fibrosis is something that is desirable. It is known that obesity and diabetes are the two causes of non-alcoholic fatty liver disease. And so this is something, and in the past, non-alcoholic fatty liver disease is only treated successfully by liver transplantation. And so this promises that we will be able to make a difference in that in the near future.
Oh, that's good.
Okay, we can go to the next one. And we've talked about type 1 and type 2 diabetes before, and we recognize that type 2 is the diabetes that most Black people have, and that type 1 is the one in which you have no insulin at all. Type 2 is where you have insulin, but the insulin is not effective. Now, we talked last week, I think, or week before, about artificial sweetness, and the argument was that we know that excess sugar is harmful, but to what extent are the sugar replacers or the artificial sweeteners more destructive than the sugar? And so there's been a number of articles that have pointed out that artificial sweeteners have their problems. And this article, in contradistinction to the previous articles, points out that yes, it does have problems, and that most of the studies that have looked into it have not been substantial enough to warrant eliminating the use of non-sugar sweeteners. And so this is, of course, I think one of the sucralose was the one that was looked at last 2 weeks ago when we talked about it. But you can see the number of different kinds of sugar substitutes. We know that the sugar in the diabetic is a problem because the management of glucose, when it's not lowered, it causes arteriosclerosis and the loss of limbs and extremities and loss of sight and many other things. So that we know that sugar in people who cannot tolerate it is destructive. The question is, which of the poison do you want to have? Do you want to have the sugar, or do you want to have the sweetener? And so this is a study this is a controversy that has been going on for some time. And I think when you're a diabetic, you don't have much of a choice. And so, well, you have a choice in the sense that you can take fruits, which are a natural source, and but sugar is kind of out for the diabetic. So so that you have to take that in consideration when you talk about saying that you shouldn't use artificial sweeteners. So, but Splenda and stevia have been the drugs that have been thought to be associated with cancer and other disease entities. And there's a lot of criticism about continuing to use these drugs. But I know it's clear that many of the studies that have identified these products as being toxic have a lot of criticism about them in terms of whether they've had enough patience and long enough follow-up. But anyway, it's food for thought and for discussion, because if you're a diabetic, then you know that sugar is not good, and so what can you do? Any diabetics or others who have concerns about this?
Yeah, I stopped at my doctor's suggestion a couple years ago using, because I like stevia. That worked for me, but she told me that about the risk of cancer. So I just drink water now, and when I for a treat, I'll have something. I might have a drink, but I try to drink tea with no sugar in it. I'm trying to develop that taste for that. I can only take that in small doses, though.
Any other comments?
It's discouraging because years ago they discouraged you from using a lot of sugar. And that's when the artificial sweeteners came out and everyone tried it and some got hooked like me. And I take Splenda. And if I was to have a cup of coffee and I was using sugar instead of Splenda, I mean, I'm tripling the dose of sugar, the amount of sugar that I put in my cup of coffee. Whereas Splenda, it gives me just that right flavor. So definitely, obviously, it's something that I see now I need to try to reduce or stay away from. I use Splenda regularly. I'm not saying every day, but pretty close. But whether it's hot coffee or a glass of iced tea, I'm using that Splenda. So I need to rethink it.
Well, it's important to recognize that you're talking about which of the two is less of an evil.
Mm-hmm.
And we know that sugar is an evil, although we're addicted to it. And the question is the artificial sweetener lesser of an evil than sugar?
Mm-hmm.
And that's what research is all about. And
Yeah.
many believe that the sweeteners are less of an evil than the sugar.
Yeah, the craving for something sweet, either artificial sugar or real sugar, it's a habit and an addiction. But
Mm-hmm.
if you can go with that, if you can go like 30 days without something sweet, sweet sweet things won't taste good to you. You'll have to readapt. I mean, you can readapt, and so it starts to taste good to you again. But you just hold on for 30 days, and you can change all that.
Mm-hmm.
I have
Any
a,
other?
yeah, I have a question. It said earlier in the article that there could possibly be some DNA damage. Is that from the real sugar or from the sweetener?
That's from the sweetener.
Okay.
The sugar already is destructive in many different ways, so we know that. But they're talking about the sweeteners.
Mhm.
I don't see equal in this article. Is equal in that same category though, right?
Well, they have the two that they've done studies on that they suggested is sucralose and stevia. Those two. The others have not been the subject of studies that indicate that they're destructive. So they talk mostly about Splenda and stevia.
'Cause I'm an equal user.
Okay. Oh, they haven't talked about equal.
Good.
Can we go? Oh, okay.
All right.
Any
Yes.
other comment? Okay, let's go to the next one.
Okay. Uh,
Well, one of the things we all know that smoking is bad for you. And one of the things that is problematical is that across the world, smoking still is a source of cancer. And one of the things that is really frightening is that probably about 20% of the people, between 10 and 20% of the people who develop cancer because they have secondary smoking, meaning that they don't smoke themselves, but they've been around people who smoke. And this is it's bad enough that if you smoke, you get cancer, but when you smoke around other people and that gives them cancer, that is problematic. And so the question is, how do we do something? As we know, there are many problems associated with smoking, and the lung disease and cancer is just one of them. There are many other associations that smoking causes an increase in cardiovascular disease as well as stroke and cancer. So the question is, what are we going to do about it? Now, I think one of the things that we tend not to spend a lot of time on is recognizing that the reason that smoking is a problem is because it's addictive, number one. Number two, people make a lot of money off it. And those two factors are what it's all about. And one of the things that I've noticed is that there used to be a decrease in the amount of smoking in the United States, but in Europe, it's really increased significantly. And so, but then also they look at the amount of money that people have made, 94 billion compared to what it used to be. Yeah. So, but it's still problematic that we still have so many people who smoke. And the fact that not only does it cause lung cancer and lung diseases, but it also exposes you to cardiovascular disease. It also causes peripheral arterial disease. And it's been associated with so many diseases that it's important to avoid ever smoking, and also to avoid being around people who smoke, which is harder to do. But it's good that places are prohibiting smoking so that you don't get secondary smoking as a problem, which far too many wives of husbands who smoke or spouses of people who smoke die from cancer, while the smoker sometimes does not. Any of you smoke?
I did for 40 years, but I stopped 15 years ago.
Oh, good, good.
Mhm.
But I took Wellbutrin.
That was the key, huh?
Yes. It
And
took
I don't see many.
the addiction out of my mind, out of my head. Taking it out of your system is easy, but you got to take it out of your head. And that's what took it out of my head.
Okay. Any other comments?
No, I was just going to say, I don't see many people smoking now. I would have thought the trend was different. The smokers have gone down.
It
But
has. It has, but in Europe, it's gone up. In the United States, it's gone down. In Europe, it's
yeah.
gone.
Mhm.
How
When
about
I went
smoke
out of the
from,
country, I noticed they have more advertising. I mean, it was just saturated with the Marlboro Man and all of that. That's still alive overseas.
Yeah, yeah,
Mm.
yeah.
how about smoke from the Canadian wildfires?
Yeah, of course, that was, yeah, that inundated New York City and the Washington DC. It didn't get out where you are, but
Yeah, it
it,
did.
it
Yeah,
did.
the air quality is real bad in Chicago right now from the wildfires.
Oh, really? Oh, I didn't know.
Yeah, yeah. This
We're
week
red here in DC.
Yeah,
it,
was pretty bad, but it's gone now. But it was awful. I didn't realize it gotten out to Chicago.
yeah. This
Mm.
week it's been so bad. You can see a blue haze everywhere in the air, and
Mhm.
Wow.
it's been so bad that I couldn't get any sleep because the bird's been coughing all night. So yesterday I put some cough drops in the bird feeder, and I was able to get some rest.
Mm.
Darryl, that's well, well, for those who wanted us to smile, that'll do it.
Yeah. Yeah.
Okay.
Dr.
Uh,
Callender, this article doesn't mention emphysema as one of the diseases.
Actually, it does up above.
Oh, it does, okay.
It's obstructive. And it's
Oh, yeah, I
they
saw
just
that. Yeah,
obstructive. That's same.
COPD, okay.
Yeah, right.
Mm.
Because you're right. That's
Mhm.
one of the biggest problems that smoking does. So
I didn't get that, but I got the peripheral artery disease.
yeah, that it does that too. Marijuana also does that too.
It does. We have a relative now that has that and is in rehab because of the COPD. And
Oh,
relatives, and it also caused the arterial venous insufficiency and all of that. But even after having it, other relatives that might see it, it doesn't dawn upon them that smoking caused all of this. They
you're right.
attributed to maybe her lifestyle or something like that. But nobody's, I guess, I don't know.
Yeah, they
Has
had
anybody
different
else
sizes in
experienced
it.
that when somebody actually gets this from smoking, they tend to blame everything else?
And
that
Bailey's
rather than-
Crossroads, like what Dunnegrass says.
Huh?
Mhm.
Somebody needs to be muted.
Okay, that they actually blame it on the real culprit of the whole thing was smoking. That started the whole ball game.
Mhm.
Very good comment. Very appropriate. Now, this is an article that we circulated, but the fact that they continue to talk about a new drug for multiple sclerosis, which is now actually being used.
Yeah.
Okay, and this new drug is a monoclonal antibodies that, and I have some of my physician friends who are actually on this treatment, and it has been surprisingly effective in terms of the fact that they only use it maybe once or twice a year, and it is very effective in modifying the way in which multiple sclerosis presents. Multiple sclerosis presents in many ways. Sometimes it causes you to be paralyzed. Sometimes it causes permanent, sometimes temporary, and sometimes it comes and goes and makes you very weak and very fatigued and unable to do much of anything. And so, and then of course it can be lethal. So the fact that they have a drug that actually markedly reduces the symptoms of multiple sclerosis is something that is good. This is not so. Well, anyway, that's what this article is about. This doesn't show it that well. But this drug is, I believe it's been FDA approved. And it's being used now. So we can go to the next one because that doesn't show up. Now this is an article, if you can show it, that tries to, yeah,
This one.
yeah, that's it. This tries to help you understand how the immune system has a responsibility of eliminating any foreign invader that comes in with the role of destroying you. And it's amazing how effective this is. And of course, we who are transplant surgeons do just the opposite of this, because we try to knock out that protective immune system so that your kidney transplant or liver transplant or lung transplant and heart transplant is not destroyed. But the goal of the immune system is to destroy the foreign invader, whatever that is, whether it's a bacteria, virus, a fungus, or protozoan. And one of the things that has been a problem is the fact that sometimes we have immune things in our bodies that prevent our own immune system from doing what they're supposed to do. And we call those autoantibodies. And we recognize how important the immune system is when we find out, for example, with COVID, if you have antibodies against interferon, and we now know that this is the reason why many of the people who died from COVID died, because they had antibodies against their own interferon. And interferon is an antibody that destroyed the coronavirus. And so when you have antibodies that are attacking your own antibodies, these are problematic. But the real understanding and the basic concept is that you have an immune system that is protecting you from infections of all causes. Some people think that cancer is a infection. Time will tell, but we know that we have antibodies that destroy cancer cells, and that's why the newest technology will take the cancer, take it out of the body, put it with your own cells, and let your cells develop forces that destroy that, and then put those protective forces back in your body. And all of this is pointing out that the immune system is the main stay for any infection, whether it's a virus, virus, or a protozoan, or a fungi, or even cancer. And most of the new cancer drugs are trying to take advantage of the fact that you have antibodies in your system that are destructive for cancer, and using those same destructive forces against cancer or whatever infection you have. And along those lines, I think the extent to which the bacteria you have in your intestine may play a role in your immune system's ability to fight off the foreign invaders as they try to get through to you. And this is an effort to try to simplify and make clear an understanding of how important the role of your immune system is in protecting you from getting infections, because with an intact immune system, you can fight off most things. Without an immune system, you wouldn't be alive.
Mm.
And that theoretically is what this article is about.
I see Alzheimer's up here.
Yeah, well, all of those are neurodegenerative diseases, which are thought to be related to the failure of the immune system to protect us against amyloid and other deposits that damage our brain. And they point out that in other articles that one of the things that sleep does is that sleep allows the brain to recover from these damaging products. There have been some studies that demonstrate that a lot of the people who are old and who have not developed Alzheimer's have the same amyloid deposits, but their brain is able to control it and keep it from destroying the brain tissue. And one of the things that sleep does is allow the toxins in the brain to be eliminated from the brain and preventing some of that toxicity. And there are new drugs now that we're hopeful that we will be able to make an impact on. So far, none of the drugs that we've had have been able to actually delay the progression of Alzheimer's.
That 8 hours of sleep a night has a different meaning when you look at it like this. It helps to clean your brain.
Yeah. Except if you have insomnia.
Yeah, that's what I mean.
Yeah.
Which is more common than we tend to think of.
Mm.
Okay, let's go to the next one, article. Now, this is an article that talks about kidney transplant recipients and the fact that we know that when you're immunosuppressed, the ability to develop antibodies as a consequence of vaccinations has been a problem. And this is important in those patients who have a normal immune response. And of course, transplant patients and cancer patients are given medications that prevent them from having a good response to vaccines. And as a consequence, the likelihood of people dying after COVID is greater in the immunocompromised or transplant patient than in other patients. And this study just points out that in the immunocompromised patient, there were a significant number of patients who did not develop antibodies, although it could have been much worse. Many of the patients, however, did develop antibodies. And in some studies, as you see here, the kidney transplant recipients didn't have an increased rate of death. And additional studies have suggested that the further you're out and the less you're immunosuppressed, the less likely you are to have a mortality from transplant, although we've had examples of that and long-standing patients who died from COVID, transplant patients who died from COVID. Any questions about this? The fact that if you're immunosuppressed or you have cancer and you're treated with medications, this then is a reason why you need to be vaccinated, because then your risk of being hospitalized or dying from COVID are decreased.
Dr. County, there's a new booster coming out in September, right?
Say again?
A new booster shot for COVID.
Yes. Oh, yes, yes. Yes, that's right. Should be, because
Mm.
most of us got that second booster shot of the probably in what, April, March. And so in September, we'll be talking about an annual booster shot.
And those patients who are immune suppressed, they definitely have to continue
Yeah, they have to.
getting the booster shot.
Absolutely, absolutely. Okay, we go to the next one. That's an interesting article that a new law comes into impact in Virginia. Then that's the only place it becomes effective. And I think the intent was to increase donation rates. At least that's the intent of it. This is what it requires employers to give employees 60 days off unpaid if they donate an organ. And this is to encourage organ donation. And when they come back, they have to have the same amount of benefits and other terms that they had before they left.
That's good.
Dr. County, that's very close to being paid.
No, they're unpaid.
No, I'm just saying the 60 days off, like you can convert leave time into actual dollars.
Well, this just says that they're unpaid, that's all. It doesn't say anything about leave time, so.
The 60 days off is leave, I don't know.
Mm-mm.
Unpaid leave.
Right.
Unpaid leave, okay.
Yeah, unpaid leave. So
That's vacation.
this is only in Virginia, so.
A lot of people can't afford it though.
Exactly. That's a
Who
lot
can
of lot of days without being paid.
Yeah.
Well, actually, we also have in the same area a grant that the governor has given that allows you to give donors money to be able to donate and pay for the travel and all of the expenses that are associated with that. That's something that has been available now for about close to 10 years. So it's reduces the disincentives. That's what disincentive is, to be off, as you said, 30 days, that's a lot of money that you've lost.
Right.
But at least they will pay for your expenses, travel and expenses to do it, and that. So it's not paying for the donation, but it is removing a disincentive for you to become an organ donor, which is what this organ donor law in Virginia is trying to accomplish.
When you donate, do you really require to be inactive for that length of time?
No, usually
I think so.
for a kidney, it's about a week to 2 weeks. For a liver, maybe a little longer.
Okay.
But for a liver, it might be as long as 3 to 4 weeks.
Mm, okay.
For a kidney, it's probably more likely a week to 2 weeks. So people are doing everything they can to try to promote organ donation. As we know, the #1 problem of transplantation is the shortage of donors. And so efforts are being made to address that #1 problem. And that becomes effective Saturday. Okay, now the next one is not so pleasant article. This is a unfortunate study that identifies a situation in which the person in the morgue at Harvard was selling bodies of people who had donated their bodies to university. They were taking their body parts and selling them. This was unfortunate in a time when we're concerned about what people do with what people leave behind, donations of bodies. And they were selling different body parts, as you can see here. And sad to say. And so the bad part about it, of course, is that Harvard is thought of as the as one of the outstanding universities in the world, not to speak of the United States. And this talks about the details. And as you know, it's against the law. And so the question is, what is Harvard going to do about it? And as you see here, this is a lawsuit too. Yeah. Apparently the same kind of thing happened in UCLA as well. So
Yeah,
what are your
it's
thoughts on
interesting.
this?
At the bottom of the article is talking about 2 dissected faces and shipped human skin to be made into leather. That's pretty gross.
Yeah, it's pretty gross. Sad. So I think the lawsuit is just going to be the beginning of a lot of activity on the part of this, and open up Pandora's box on if it's done here, the question is, where else is it done?
Don't mention China.
Well, China is they do. These are bodies that are donated. China, it's the question is they're taking people who are alive and using their, at least that's what they claim, that they're taking prisoners and using them as donors. But that's, I'll bring an article on that maybe next week. Yeah. Any other comment? Except, and although it speaks for itself, so, and it's not something that Now, that next article right below it, exercise may raise genetic risk for diabetes. We could look at that one too. Oh, well. Okay, well, just do the next article. Don't worry about it. You just do that. And this is an article that talks about the right for a doctor to dismiss a difficult patient. All physicians have had patients who listen to them and patients who do not listen to them. And we have patients who are drug seeking and patients who are aggressive and threatening. And so the question is, what can you do about that? I mean, can you discharge a patient? I've had, in my whole career, I've had about 2 patients who I allowed to go to somebody else because they wouldn't follow what I was doing, and I felt that was dangerous to them, and so that they needed to get another physician. The one thing that is clear is if you discharge somebody from your care, you have to find somebody else for them to be taken care of. Otherwise, it's considered abandonment. And and as this says, 90% of patients have dismissed at least one patient during their career. And what you have to do is to find another doctor who will take care of them. And if you don't do that, then you can't discharge them, because then it is abandoned. Now, because autonomy is one of the most important issues in practice of medicine, which means the patient has the right to decide yay or nay, and they also have the right to choose another physician. And you cannot be forced to take care of a physician if they are not willing to follow your recommendations, because the patient has rights. And then this then becomes an issue that becomes very worthy of discussion. What are your thoughts about it?
Dr. Callender, on an unrelated topic, I know someone who got banned from being picked up by the Uber Driver Association.
Why?
Because of, non-compliance.
Oh, non-compliance mean they wouldn't pay?
They wouldn't shut up.
Okay, any other comments on dismissing, the doctor dismissing you or you dismissing him? Because go ahead.
I had a doctor one time who I didn't like I didn't like the way that he spoke to me. And it started with, I didn't like the way he spoke to his office staff and how he didn't listen to what I had to say to him. So I dismissed him. I
Good.
didn't follow his recommendations because he didn't speak to me as an adult. He spoke to me as, it was almost like, you do what I say and I know best. And that's why you're coming to me, because you don't know anything. And that was his attitude. So I stopped going. I didn't go to him any longer.
Well, that's what you should have done. I think it's important to recognize that it's a two-way street, that you have the right to get a second opinion and you have a right to dismiss him just as he may have a right to dismiss you.
Right.
Any other comment on the subject?
One other comment is that if the patient dismisses a physician, I don't think there's a problem with the law. But if a doctor, it says here, it could possibly be a lawsuit if a doctor does it for illegal reasons such as discrimination based on race or gender. You know, in other words, if a doctor doesn't want to service somebody that's LGBTQ, then they could possibly be subject to a lawsuit.
Any other comment?
You always come across people that are combative, very offensive, and etc. And a doctor just, you know, even in every line of work, there are always those type of people. Most of the time, you can, you know, even if I was teaching in there and you have a child that is just off the hook, very combative, and you can't deal with them, you can put them in somebody else's classroom, or a doctor, he has to recommend them. And if you recommend them to another doctor and you know that this person is extremely combative and sort of mentally ill, won't that other doctor dislike you for referring that person to them?
Well, you have to tell them the whole story.
Okay, and
And,
then they have a choice of saying, I don't want that patient.
That's correct.
Then you're left on the hook with taking care of that patient because nobody wants them.
Well, I think that if you made a reasonable effort to do it and that situation still stands, you're probably in good shape, because you've made if you make a reasonable effort to get that patient taken care of by somebody else and they feel that he's too aggressive and they're not willing to do it, I think that case will stand. But most of my patients who are aggressive like that, they need to be treated. And usually they need psychiatric help. And I have been able to get that for them in the past. So that was never a reason for getting rid of them. Although I had patients throw things at me and other things, most of the time having psychiatric support helped with that. So that was really a reason for why I got rid of them. It was usually because they were not willing to follow my recommendations, and so I felt that they should be treated by somebody else whose recommendations they could follow and they could live with. And it's a rare occasion, but so that situation of the mentally ill patient usually is handled by having psychiatric consultation. Any other comment on that subject of dismissing and that?
And the patients didn't mind that you brought in a psychiatric person to talk to them?
No,
That's
no,
good.
they accepted the treatment and calmed down. I had one patient that threw a chair at me. And so we got him treatment and he got better, and
That's good.
yeah, so. Any other comments about that subject?
Yes, good morning, good morning, good morning. This is Elizabeth. Mary Ellen sort of summarized part of my experience, the main part. Because I had worked in healthcare 20 years and the thing about it, whoever you talk to, you never know what their experience is. You never know their knowledge and their wisdom. And I had an experience with my daughter. We had moved to a new area. And so I was using my husband's insurance. And my daughter had a severe cough. So I took her to the doctor. And one of his interns saw her, gave a prescription. And I used it for 7 days and no results. And so I went back to the doctor and I told him that the medicine is not working. I'm not having no results. And so the intern that saw me said that maybe you're not doing it right. I said, well, I followed the directions. And I'm a person that reads the direction each time that I use anything. And she was not very nice. And like Mary Ellen said, I noticed that they were treating their staff the same way. And so the next time I went for a visit, I was called into the doctor's office, and the head of the practice rather, and he told me that he could not service me anymore. And because I should do like the rest of his patients, I should bring in my child every day. And because I know billing and diagnosis and treatment and billable diagnosis rather. And I looked at him, I says, no, to me, I do not totally agree with that. Well, you should do what the other patient do. They bring their kids in here every day for us to check them. I says, well, that's your opinion. But he says, well, we can no longer service you because you're not following directions. I said, well, my child is not getting any better. Well, we can't do anything else for your child. Well, like Mary Ellen experienced, I knew to call the insurance company, and I voiced a complaint. And so I just went on to another position. But those situations do happen.
Thank you for sharing. Okay. If there are no other comments, this is an article that we've talked about before, that we know that some of these terms may not be familiar to you, so I'll explain them. What they're talking about, reanimated donor hearts, means that the heart stopped beating and you started beating it again. And in the past, there was concern that if the heart stopped beating and you got it started beating again, in a timely fashion. For example, if you got the heart start beating within 8 minutes of cessation of the heartbeat, then the brain could still be alive. But if you got it started after that period, the brain is not alive, so brain death would be occurred, and so the organ could still be used for transplantation. And that's what this is saying, that even though people, for example, most of the donors that we have are associated with brain death, which means that the brain is no longer capable of functioning. None of the parts of the brain are capable of functioning. And so most of the donors we have occur from brain death, which means the heart is still beating. Okay, so the separate category is the category in which the heart has stopped beating, and that's the cause of death. And so then that heart can then be perfused and then used for donation for somebody else. And this is now demonstrating that many of these hearts that are used in this fashion function well, and that this is another source of donation. Now this becomes critical because the number of patients who are waiting for transplants is about 100,000. The number of transplants we do is about 40,000, so that you got 60,000 people who don't have organs, and as a consequence, 15 to 20 people die every single day because of the shortage of donors. And so the need for organs becomes critical. So this is another source of donation, situation where the patient is declared dead because their heart stopped beating. And in this kind of situation, the heart can be used for transplantation, thus helping us address the donor shortage. And that's what this article is all about, indicating that whether the patient is a donor because the heart stopped beating or because the brain ceased to function, the organs can be used for transplantation. So, and to make a long story short, that is what this article is all about, that the communist cause of donation is related to the definition of brain death, but that people who die when the heart stops beating can be used for donors as well with good results. And that's pretty much what they're saying, is because we have this donor shortage that we should take advantage of any death that occurs and when organs can be used. Now, if somebody dies, 8 organs can be used to save somebody's life. And there's about 60 tissues that can be used to improve the quality of life of people. So that in essence is what this article is all about, indicating that there is a donor shortage that is associated with loss of life, and the more ways we can use organs from people who've died, the better off we can be. Any comments on this subject, which is the reason why we're talking about using organs from other species like pigs and the primate model, and also we're talking about regenerative medicine and growing organs and that kind of thing, and also taking organs that are damaged and fixing them up and then using them transplantation, because we're talking about 15 to 20 people dying every day because of the shortage of donors.
Dr. Callender, I'm curious as to if you're saying the person is pronounced dead because their heart stopped, but their brain is still functioning. Is that what you say?
No, I'm saying
okay.
in those people. Yeah, well, okay. In other words, there's a time limit. So if you start somebody's heart and they have not been, the heart is not, 8 minutes has not elapsed, then the brain can be reconstituted. So we're not talking about that. We're talking about those people for whom this is much longer than that, and so they're declared dead, and the brain is dead, and everything else is dead. In contradistinction to the person for whom the brain is dead, but the heart is beating, which is the commonest source of organ donation.
Okay. All right. I had it backwards, I guess. Okay.
Any other comments or questions? Because sometimes this is not as clear as it can be, and sometimes my trying to clarify it is not good. So if you have some questions so I can clarify and make it plainer, I would welcome the opportunity to do that.
Dr. Callender, go ahead.
Dr. Callender, how long? I mean, you know, my fear, because I've signed up to donate my body, my fear is that I will die in my home and they won't find me. So my organs won't be of use. How long is how soon do you have to harvest a body to be able to use it?
Okay, for organs, you need 60 minutes. For tissues, 24 hours. That's the time frame. 60 minutes for organs, 24 hours for tissues.
Okay.
Dr. Callender, now, a couple of organs have shorter time span. You mentioned 8 minutes on the heart. What about?
No, I didn't say 8 minutes on the heart. I said if the heart is stopped for longer than 8 minutes, the brain is dead.
Okay.
Okay, because now we have situations where we can keep the heart, if the heart is taken out, we can preserve it on ice, or we can preserve it on normothermic perfusion for 8 hours. So we have ways of preserving the organs after they are removed. The old-fashioned way was putting them on ice. And for example, on ice, the kidneys could be preserved for 24 hours, actually on preservation machine for as long as 72 hours. The heart was only 8 hours, and the liver previously was 8 hours. Now we have machines that can allow the liver to be perfused for as long as 24 hours, and the kidneys and lungs and other organs can be used for 24 to 48 hours. So the preservation times now have increased.
That's
Before,
good.
before it used to be 48 hours, but now we have ways of preserving them that allow us to preserve them for a longer period of time. But if you get those organs after 60 minutes, then they're not going to be able to be used.
So back to what Mary Ellen was saying about maybe dying at home. After 60 minutes, even though she's donating her body for scientific research, they could not use.
They can use it, but they
Oh,
can't
that's-
use it for an organ donation.
Okay, that's what I wanted to make clear.
Okay.
Yeah.
Yeah, okay. Yes, they can still use it for
Mhm.
purposes of donation for
Research.
for research
Yeah.
and for giving it to a medical school.
Yeah.
Right.
Okay.
Yeah. It's kind of what I.
And your concern is a valid one, and that's one of the things that when you live alone, why you need, one of the things that we talked about and some time ago is if you live alone, how do you let people know if you're fallen down or unconscious or something like that? And so do you have something that monitors you and that calls somebody if you suddenly stop breathing or your heart stops or your blood pressure stops? And so most people who live alone, their families tend to get them, have some alarm system that when something happens to them, somebody is notified. And
Yeah,
if
I've got
you live alone and don't have that, then it's a good idea to get it.
an Apple Watch with a fall sensor that if you don't respond, it'll ask you the question, did you have a hard fall? And if you don't respond, the watch will call 911.
Yes, that's the kind of thing I'm talking about. And that's the thing that people who live alone should probably have so that if they fall or something like that, somebody will come immediately so that the situation that you talk about would not occur.
Yeah, there's also that med alert chain that you can wear where you can push a button to call 911.
Right, and then in a situation where you can't push a button, that's the situation that you need to have as well. Because as Darryl stated, if you don't respond to the conversation, then they automatically call 911. And that's what you need to have. Because sometimes you just have a stroke and you can't respond. Or you fall down and hit your head and you can't respond. So that's the situation where you need monitoring. And so those who live alone, those are things that should have in place. It's recommended that you have that in place. Was this a comment or question? Okay, let's go to the next one. This is an article we talked about before, actually, that Obamacare still covers preventive care, an ounce of prevention worth a pound of cure. And Trump had tried to eliminate most of Obamacare, but the courts have upheld the preventive care clause, so that's still going on, and hopefully we'll also go back to the point at which we need to recognize healthcare as a right for all Americans, which we do not have yet. And let's hope that that continues to be sought after, because that is one of the biggest obstacles to having access to care for many of our citizens, particularly people who are of color. Okay, I think that's the essence of that article.
Mhm.
Let's see, we can probably do one more.
Okay.
And we also need to be sure that John Buchanan is okay.
Yeah, he was on the line. He's in New Mexico, he said.
Oh, okay. Okay. I think, let me see, I think we've done most of these.
Yeah, we talked about superloads,
Yeah, we did talk about that. So.
but we didn't talk about depression.
Didn't talk about what?
It says that it can cause depression, it looks like.
Oh, no, that was a different subject. Let me see if there's anything there. Oh, let's look at that medical students aren't showing up to class. Did we discuss that before?
Oh,
We
yeah,
may
we
not-
did. Yeah, we did.
Yeah,
Okay. Well, let me see.
What about menopause and long COVID?
We talked about that too already. Talk about all of these things. It's interesting. You don't have some of the ones that I sent you. Go up to your top. Go up to the top. Let's see if you have any. You don't have any. I sent you a lot of. But I guess you probably didn't get the one that I sent last night. Okay. All right. Let me see. Oh,
The ones that are bolded, I think we haven't talked about, I think.
okay. We talked about list diving. We talked about that Christian docs claim victory over state and aid dying laws. I put that in there, yeah, because what they're talking about is that they want you to be able to. They wanted some docs to assistance in helping people die, and the Christian doctors sued because they said that's not what Hippocratic oath is all about. That they should not participate in your assisted suicide, and that is not what doctors do. And so I wanted your thoughts about that. Should physicians assist in somebody's death and somebody who does not want to live anymore?
I got an idea, Dr. Callender. I think that general practice is saying that they should not, and maybe another field of medicine, a brand new field of medicine, where you can go to doctors that have a license to assist with suicide as necessary.
Well, in states, for example, DC wanted to be one, but I think
Congress,
Congress
yeah, they
prevented it.
did it.
Yeah. But there are some states now in which it is illegal to do that. And so if the state has that as illegal, then you can find a doctor who does that. But it's interesting. Your idea is a new one that flies in the face of the Hippocratic Oath, which is that your job is to save lives. And you are saying that there should be a group of doctors whose job is to shorten lives. And that's an interesting, controversial idea that many people would have take issue with, although I think Dr. Death, Kevorkian,
Okay.
Yeah.
probably would agree with you that there's a category of patients who we can't do anything about, who would like to end their suffering. And that's what you and in fact are in agreement with Dr. Kevorkian on, that there's a category of patients for whom every second they live is torture. And we should be able to do something about that. And we haven't gotten to the point where that is something that we agree on in every state. So it's something they agree on in Sweden, but not here in the United States. So any other thoughts? Tatum's come with an interesting idea. What are your thoughts about that?
I thought that doctors that work in hospice, I thought they were kind of easing you into it.
Yeah, but they're not. That's an interesting concept, because my opinion is the same as yours, is that the hospice doctors give you enough medication for you to die peacefully. But theoretically, they're not supposed to be hastening your death. They're just supposed
No,
they're supposed to be
but
allowing you to die painlessly.
my aunt just died on Juneteenth, and she was 103 years old, and she had been in hospice for 10 days, and they brought all this medicine to the house, morphine and all this stuff, and she never took any of that kind of medicine, but they brought all that. They did bring some oxygen, and before they could almost get it set up and everything, what happened was she stopped eating, and then she wouldn't open her eyes, and she did that for a few days, and they called her into hospice. Soon as hospice got in there, it was like her eyes open. She asked for the telephone. She started making calls and asking for food. And then 2 days later, she went back to the same thing. But before they could get the oxygen set up, and they had the morphine, but they didn't tell my cousin how to use it. She passed away. But she had a whole box full of morphine.
Well, I'm glad to hear they didn't use it.
Okay.
No, they didn't use it. But what I'm saying is, I thought that's what
No,
I thought that's what hospice is supposed to aid you in dying, help
not.
you to.
It really is not supposed to aid you in dying. It's supposed to help make dying painless. It's not supposed to.
Oh, okay.
It's not supposed to hasten your death.
Well, I didn't think hasten. I mean, I thought like ease you into it.
Well, that is what they're supposed to do. No, you're right. They are supposed to make it ease your pain and
They
make it.
say palliative care.
That's what it is, because they're supposed to make your dying easier for you, but not hasten it. Right.
Right.
But what John is talking about is those people who hasten it. Yeah, and he's saying they need to be licensed to do that.
Socrates was sentenced to death, and he got to choose his method of execution, and he chose hemlock, and he mixed it with tea, and it killed him. And you can order poison hemlock from Amazon for $8.97, and it will do the job.
Wow.
That's suicide.
Why was he sentenced to death?
For corrupting the youth of Athens because he was anti-democracy. So he told the youth that democracy was a failed system. And there was a Athenian jury of 100. It was called a solon. 100 people voted on at his trial, and 51 convicted him of corrupting the youth of Athens, and the penalty for that was death.
Wow.
That's
Hmm.
that's sad.
Yeah.
Yeah, that's sad.
Yeah,
Well,
it should have been a 2/3 vote.
Well, tell
That's
that to the
alarming.
Athenians. You know, it was their rules, and so they did it their way, not John's way.
No, that's not mine. That was Robert's rules.
Well, they didn't do Robert's rules back then.
Okay. Any other comment before we close?
One other comment I wanted to make was, you know, the idea of having a license to assist in death is similar to an abortion clinic. You have doctors and clinics who specialize in abortion. Isn't that similar?
No,
No,
I don't think so. But I mean, you know,
no.
because yeah, I don't see the similarity. But you might, because your perspective is that those people are alive. So it all depends on your perspective. Some of the doctors feel that those people aren't alive. So so I think it's different. I think it's different.
Yeah. I guess Christians would talk about what is life.
Yeah, yeah. When does life begin?
Yeah.
Right.
Yeah.
Yeah. Well, okay. Well, we've had an interesting hour and a half. And any other comments before we close? I wish you all. We're going to July the 4th shortly, the weekend before I meet. Any thoughts
One
about
comment
that?
I have is 84 years old too old to get a lung transplant?
The contraindications to transplantation have nothing to do with age. They have to do with no, but you asked specifically about lung transplant.
Lung.
And yeah, and that is a particular, for most transplants, that age is not a contraindication. For lung transplants, I don't know what they have identified as the age for which they stop doing lung transplants. So that's a specific area which I'm not clear on in terms of what is the age limit.
Okay.
For heart transplants, it's going up to 70. It's interesting. When I started transplants, it was 50.
Oh,
And now age is not a contraindication for transplantation. Comorbidity is. In other words, if you're healthy and 80, you can have a transplant. 84, you can have a transplant. Now, lung transplant is a different issue, because that's a specific, and the mortality rates are different for lung transplant in contradistinction to kidney transplant. So I don't know the answer to that for lung transplant.
Dr. Callender, today, Sylvia Davis is attending the funeral of Mrs. Dorothy Fontroy, Reverend Fontroy's wife passed, and the funeral's today at 11 at New Bethel Baptist Church.
Oh, okay.
And if you remember, Walter Fontroy, our first.
He's still alive, right?
Yes, he is.
Yeah, he is.
Mm, mm.
Doing well too.
Yeah, his brother. Well, he also has dementia, right?
Yes, he does.
Yeah, and his brother is alive too.
Yeah.
Right.
Yeah, yeah,
Billy Fontroy, yes.
yeah, yeah.
And
yeah.
he's doing fine. He was one of the aviators, Billy Fontroy. or something like that.
Yeah, he's up there. He's up there. Yeah.
Mhm.
He's amazing. Yeah.
Mhm.
Yeah. Okay, well, it's good. Thank you for all attending and thank you for everything you've done. And we have let's see, I think John Buchanan had somebody who's going to present to us on July the 13th. I think he's a psychologist.
Okay.
So, okay, so until July the 6th, huh?
Yeah.
Okay, have a great weekend and
Okay.
I'll be listening.
Happy holiday, everyone. Be safe.
Bye.